Good afternoon, everyone. Myself, Dr. Kirti, Assistant Professor, Physiotherapy Department. So today we'll discuss about tension test as a part of neural mobilization. Neural tension test is an established component of neuroorthopedic examination in which tension in nerves is increased, thus reproducing the sign symptoms proving the neural involvement. So, uh, this information should be elicited from all tension tests. Symptom response, a range at which symptoms start, whether symptoms are the one that the patient complains of or what the symptoms are at the limit of range. The resistance encountered, an assessment of both symptom response and the resistance must be made after each component of tension test is added or subtracted. Positive tension test, it reproduces the patient's symptoms. The test response can be altered by movement of distant body parts. There are differences in the test from the left side to the right side and from what is known normal. So this is the classification of neural tension test. We are having the upper limb, spinal and lower limb tension test. So upper limb tension test, also known as the Elvis test or brachial plexus tension test. So in upper limb tension test 1, so median of dominant utilizing shoulder abduction. In 2, median of dominant utilizing that shoulder depression and external rotation. In 2b, radial nerve dominant utilizing the shoulder girdle depression and internal rotation. And in 3, ulnar nerve dominant using the shoulder abduction and elbow flexion. So basically in tension test 1, the subject position is neutral and therapist right standing holding the hand, subject arm on therapist thigh. So while maintaining the depression at shoulder, uh, patient arm abducted to 110 degree, forearm supinated, wrist finger extended, shoulder laterally rotated, elbow extended and lateral flexion of neck. So symptom and symptom change must be identified. Also elbow extension is preferred at the last component, so precaution should be taken. Indication symptoms anywhere in arm, head, neck and thoracic spine. So usually the normal response is deep stretch or pain in cubital fossa, a definite and tingling sensation in thumb or first 3 fingers, or there is stretch in anterior shoulder area. In 2, the subject lie diagonally with scapula free of bed, shoulder depression, abduction 10 degree, cervical lateral flexion, elbow extension. So same as those for the limb tension test A and B. Basically, indications are cervical, thoracic, upper limb symptoms, or in tennis elbow, decurving disease. Usually compare with the other arm for normal response, and symptoms should be expected in the innervation field of the median or radial nerve. In 3, the subject will be in the neutral position and shoulder depression, cervical lateral flexion, wrist extension, forearm supination, elbow full flexion, shoulder abduction. So indications are cervical, thoracic and upper limb symptoms. Compare with the other arm. In asymptomatic young people, a common response is a degree of burning tingling in ulnar nerve distribution in hand or medial aspect of the elbow. So next we are having the slump test. So patient sit with thigh fully support and knee together, and usually the patient hand are behind the back and asked to slump or sal, and overpressure is applied to lumbar and thoracic in attempt to bow the spine rather than hip flexion. Ask the patient to bend chin, also extend knee and dorsiflex ankle actively. So usually indications are spinal symptoms seen in position of slump, like while getting into car or kicking a football. So on slump, nil normal response, slump or neck flexion, pain in T8, T9 area in 50% of the cases. Also pain in hams, restriction of knee extension, which should be symmetrical. On release of neck flexion, symptom reduced in all areas. So in this way, the slump test is usually performed step by step. Passive neck flexion, patient position supine, and therapist passively flex the neck and chin. Symptom response, range of motion restriction throughout the movement noted and analyzed. So usually indicated in spinal disorder, headache, arm leg pain of spinal origin, lumbar pain, sciatic pain. Usually the normal responses, patient is asymptomatic, may feel a pulling at cervicothoracic junction. So in supine, other Spinal components are neutralized, thus allowing better interpretation of result. Also, you can do some variations like passive neck flexion, upper thoracic flexion, passive cervical extension. Prone knee bending, patient in prone position. Therapist grasps the lower leg, flex the knee. Range symptom response resistance throughout the movement is noted. So usually if there are knee, anterior thigh, hip or upper lumbar symptoms, so we can compare with the contralateral leg pulling or pain in the quadricep area. So SLR subject in supine with trunk, hip in neutral position. Therapist place one hand under the calcaneum, another proximal to knee. The leg is lifted perpendicular to bed as solid lever moving at a fixed point in the hip joint. Hand above knee prevent knee flexion. So these are some of the indication like posterior thigh pain, radiating pain, low lumbar pain. And normal response is range of motion symptom response and restricted restriction throughout range of motion, which can be compared with the other leg. Thank you.